Good afternoon. This is Bryson. You are listening to GenRX Radio on 90.7 WCLH, Wilkes-Barre, Scranton, Hazleton. Keep it locked.
My name is Jamie, and with us we have Dr. Thomas Franco, an associate professor of pharmacy practice here at Wilkes University Nesbitt School of Pharmacy.
Always happy to be here.
We will always have a licensed pharmacy faculty member with us on the show to ensure accurate information goes out to you. We are here to bring you weekly topics centered around the opioid crisis, proper medication use, and disposal in not just my community, your community, or our listeners' community, but it is all of our community. Be sure to tune in every Wednesday afternoon from 1 to 1:30 p.m. right here on 90.7 WCLH for new topics and discussions.
So last week we talked a lot about stigma reduction, about different types of chronic pain such as musculoskeletal pain and neuropathic pain, and what it is like to have chronic pain. Can you give us a little recap, Dr. Franco?
Yeah, we compared a lot of it to Carolina barbecue sauce and your how you come to find the best wing sauce that you like or how to go to a buffet. So we did talk a lot about how to approach chronic pain treatment and a little bit about stigma. And yeah, that was pretty much last week.
Thank you for the recap, Dr. Franco. So this week we're going to talk about a hot new development in the world of chronic pain and substance use disorder. The CDC proposed new guidelines for prescribing opioid painkillers last week. This is big news because it is the newest development in guidelines for opioids since 2016. These guidelines are just in the draft form, so they might change a bit when they are finally released, but for now it's really exciting news. When these guidelines were released in 2016, it sparked a nationwide change in law surrounding opioid prescribing.
So before 2016, the opioids, we would say, were prescribed too loosely. And then with the new guidelines that came in 2016, there was a hard stop of prescribing opioids. And now in 22, we're excited for what they're calling the Goldilocks solution. So the new guidelines are a little bit of more prescribing with a little bit of less hard stopping. So these new guidelines state, as we talked about last week, that there are cases where opioids are necessary for our patients. And in these cases where they are needed, it is recommended to use the lowest effective dose at first and prescribe the immediate release formulations over long-acting.
Yeah, when those guidelines came out in 2016, it got bad. So many prescribers just cold turkey people off of opioids because the CDC says this, and there was a fear that people could face legal issues or potentially even criminal issues. But what ultimately did happen was it put a lot of people kind of out into the lurch of, I no longer have my medication. And it wasn't people who had some type of opioid use disorder. They were just people in need of help. Now, that said, as you mentioned, prior to 2016, like, people were making it rain opioids out there. It really was out of control. So and again, I haven't taken a look at the new guidelines yet. I actually have a meeting with APhA about it tomorrow. But what I'm thinking that these are going to look at is to say, this is a subjective condition, and there is no cookie cutter approach. Every single person is going to be different. So I'm hoping that it gives more in terms of assessment, nuance, clinical considerations, rather than a if this, then that type situation, which is what the old ones did.
Yeah, so when I looked at it, that's exactly what it seemed like they were doing. So something I think is important with these new guidelines is that they seem to have changed from more policing tactics with dose limits and one-strike policies on misuse to more caring guidelines. In the past guidelines, there were dose limits that were supposed to be seen as more of recommendations. However, like Dr. Franco said, people feared penalties, so some physicians used strict codes and even would drop people from their practice. As a result, some patients were tapered too quickly, and some patients were dropped from practices. So the new guidelines now suggest dosing based on the patient as a whole and what is best for them individually. And also, another thing I noticed was that patients that had a positive drug test that showed illicit use were also dropped from the practice. And the new guidelines seem to showed that they're recommending counseling and treatment options to those who need it, and it's actually like specifically in the guidelines to help in what should be done.
That's a delicate balance. because yes, if you have somebody who's taking opioids for pain, and we do a urine toxicology screen, which is like normal. That's no different than someone with diabetes and we check their blood sugar. It's just a routine safety check that we do. And it comes back that they have whatever in their system. The balance that has to be struck is we don't want to put patients at risk of harm. That's our most important thing. So the first rule of medicine is to do no harm. So if I know that somebody has something in their system, let's say it's cocaine. Somebody has cocaine in their system, and I'm giving them an opioid on top of it, so oxycodone. Does that put them at more risk of having breathing issues, heart problems? And that's where I have to strike it. What was happening before was people would see a urine screen get lit up or come back positive for something it ought not be positive for, and people were getting kicked to the curb. Get out of here, I don't want to deal with you. Now, that person is going to be without their opioids, so they're going to go into withdrawal, and they're probably going to end up using more. So what should be done is we need to find the balance of how do I prevent harm from coming to the person, but use that, which is what we should have been doing the entire time, and
Definitely.
credit to those who happen, use it to have a discussion to get the person into treatment for whatever, or minimally an evaluation for substance use disorder.
Yeah, I know you talked a little bit about tapering people off of it. So what are the risks of not tapering off of opioids and just cold turkey stopping opioids?
Bad. Not necessarily death, though death can happen if, let's say you have a heart condition or a seizure history or some other chronic medical condition. The general ugliness that is caused by opiate withdrawal may exacerbate that, and you have a problem. But in otherwise healthy people, opioid withdrawal is just the most god-awful feeling ever. It's the way that people have described it to me has been, imagine the worst flu you've ever had and the worst panic attack you've ever had on top of each other, and that's what it feels like. So when people, what was happening, and we saw this not necessarily with what happened in 2016 when the guidelines came out, but back in 2010 when OxyContin got changed to being crush-proof. What happened was people could no longer get it because it was crazy expensive. So they went into withdrawal, and the way to mitigate that withdrawal was to go to heroin because heroin was cheaper, and I can go out on the street and get it. I don't have to go to a doctor and a pharmacy to get it. So we saw the same, not the same thing, but you did see people who were in pain go into withdrawal, and not necessarily because of the withdrawal, but because their pain was high, they could turn to something illicit. And even when we look on the street, the majority of people who, let's say, use, it could be use any substance, but primarily non-prescription buprenorphine, so medicine like Suboxone. The biggest reason they use that is to prevent withdrawal, not to, quote, get high. So, yeah, opiate withdrawal feels like garbage, and people can, will be doing whatever they can to no longer feel that way.
Yeah, those are some great points, and just another reason why really loose guidelines and really caring guidelines are really important. And I think the one thing I liked about the new guidelines was that they're really encouraging of alternative therapies, aside from medications. And I know we talked about in the past that the ultimate goal of chronic pain therapy is to get a patient into physical therapy. This week, in lieu of the new guidelines, I thought this would be a good time to talk about some more alternative therapies. And I think one of the more interesting ones I saw was yoga. So, funny story, but I've actually done yoga before, and I'm not going to lie, it is a lot harder than it looks. I'd say I'm generally pretty fit, but yoga kicked my butt when I did it. It works just a lot of different muscles that I've never used before, and it had a really weird effect on my body. But I think another benefit of yoga is the focus on breathing. And that seemed to have a really calming effect, and I felt really zen afterwards. And I could see how this could be really beneficial for someone suffering from chronic pain. So, Dr. Franco, have you ever seen a patient try yoga for their chronic pain?
I have not personally seen a patient of mine do yoga as a form of treatment. That said, I know of people who are very much into yoga as a type of exercise pattern, and they don't have back pain. And we don't have to go into necessarily the why behind that. It all has to do with how you strengthen the muscles of your back. But I will agree that yoga is for the inexperienced, and I will raise my hand on that one. You're not walking for a few days after the first time you do yoga. I remember the very first time my wife wanted to do it at one of the gyms around here, and yeah, they're like, bend this way, turn over here, and just hold it. I'm like, I don't bend that way.
No.
It's not working. So to people who are very good at it, I'm sure it takes years of practice to do it. You can get extremely strong and flexible in the process, and doing that will severely minimize the likelihood of you developing significant, especially lower back issues long term.
Okay, great point. Great point.
Yeah, I love yoga, and I agree with you guys. It's very hard at first to get into it. So now we're going to take a quick break, and when we come back, we'll continue discussing some more alternative therapies that can be used to help mitigate pain. Thank you for listening to Generation RX Radio. Keep it locked on 90.7 WCLH until we return.
How many times must I see you in here? Why can't you sit down and just keep quiet? Please tell me now what you've done this time. Your teacher's in tears, why can't you just keep quiet? Ink on my skin and holes in the wall. When I get tired of running, I'll just start to crawl. They put up these barricades to get me to stay, but I get so bored, I just wander away. Do as we say, we're here to keep you safe, but we can't take all this noise, so please keep quiet. Go on the bath and wash the dirt off your face, and tell us where you've been and just keep quiet. Do children buy and everything's intact? Now everything's broken from how I act. Let fire flutter, I bid you no bother. If no is my answer, I'll find one and barter. Now I begin to see what you mean. This world will never accept someone like me. It's time to trade in my juice for afternoon tea. These treasures are now just trash to me. It's time to stop building castles and come out of the sand and start building houses on sturdier land.
Welcome back. You are listening to 90.7 WCLH, Wilkes-Barre, Scranton, Hazleton. For those of you just joining us, you are listening to Generation RX Radio. My name is Jamie, and with us we have Dr. Franco, Associate Professor of Pharmacy Practice, and my co-chair, Bryce. Before we move on, let's do a quick recap of the first half of our show.
Yeah, we were talking about the new guidelines that are coming out. It's probably sometime later this year from the CDC for opioid use. And we started to talk a little bit about alternative therapies, most recently yoga, and how it's way, way harder than it looks.
Yep, definitely. We are here to bring you weekly topics centered around the opioid crisis, and not just my community or your community, but our community. Be sure to tune in every Wednesday from 1 to 1:30 for a new show. For the second half of our show, we're going to continue our discussion of alternative therapies for treating chronic pain.
So jumping right back into our discussion, one that I find interesting is acupuncture. So it seems counterintuitive to me to poke needles into a part of my body that already hurts. But many people enjoy it and say that it works for them. Acupuncture works by inserting small needles into certain areas of your body to relieve pain. Some acupuncturists may also twist the needles while they're in your skin or apply a small electric current to the needles. So Dr. Franco, where does this fit into therapy, and what patients might we recommend this for?
First off, those who aren't afraid of needles or
Definitely.
or having an
That's a good
electric
point.
current hooked up to their needles. Clearly have not had acupuncture done. But when I worked at Geisinger, we actually did have an acupuncturist about once a month come into our pain clinic and work on people, and people said they had great outcomes. So the evidence that's out there says that for some situations and some people, which is pretty much all of pain management, all the evidence says in some situations for some people it works. What I usually tell people for whether it's acupuncture or anything else, I say, look, if it's safe, legal, and effective, go for it. Knock yourself out, because what works for me won't work for you. So those are my only two. I should probably add affordable in there. So safe,
Right.
legal, and affordable, then knock yourself out. Give it a shot.
Yeah, it was interesting too, because I also found that a lot of the studies point to that you have to believe that it's going to work. So forcing someone to do this treatment is not going to work for them. They have to want to and enjoy it, and it has to work for them.
Oh yeah. That's anything. If you don't believe something is going to work, then especially for something that you perceive, like I can't perceive high blood pressure, but I can perceive pain, depression, anything like that. So most of your neurologic and psychiatric conditions that you just feel, you don't actually have objective symptoms. That's where you need to have the buy-in. So, and that's part of what our job is we do a lot of education that the pill is not the only answer. It's a part of the whole, but it's not the entire thing. So that's a hard thing for a lot of patients, especially, we're socially adept at pills fix everything, which they don't. That getting that piece of education across and instilling that belief in people is really important to helping them be successful with this type of treatment down the road.
Yeah, definitely. Great points, guys. And I think acupuncture is something that a lot of patients should consider. Like, it might be a little more work to try and get to the appointments and stuff, but I think it could really have some great outcomes. And I wanted to bring up a more controversial alternative therapy for chronic pain, which is medical cannabis. And this is obviously a huge topic that we want to explore more in future episodes, but today we're just planning on introducing it and talking about it a little bit. But anyway, I think almost every prescriber has an opinion on it, and I think this therapy is a little more tricky than others. I think every healthcare provider has been taught to follow the evidence, and the weird thing with medical cannabis is that there isn't really great evidence on its usefulness for chronic pain. It's kind of like equal to placebo when it's compared to that. And it seems like on a case per case basis, it is really helpful. Like some people that have used it for chronic pain say it's really, really great and it really helps me with my chronic pain. So this is kind of tricky, but Dr. Franco, how do you balance the fact that this therapy is very helpful for some, but evidence-wise, it really hasn't proven itself yet?
Well, there's some evidence that's out there, and there's a whole lot of legal red tape as to why we can't have good evidence on it, at least at this time. But first thing that I think is important is that in Pennsylvania, there has to be a pharmacist or a physician, and 99.99% of the time it's going to be a pharmacist at the dispensary. So it's not like in other states, like in Colorado, where anybody can do this. So Connecticut is another state that has to have a pharmacist there. It's actually the minority of states, but that's a good thing because that person's going to sit down and go through all the meds. They know all these different strains of the product, and they can try to pick something that won't interact with other things you got going on. When we look at what evidence is out there, though, and it's interesting because this is one of the major issues that is always brought up at the Utah program. So knock on wood, everything comes back with that this year. But the three areas where they found a lot of evidence that it actually does work is in certain types of neuropathic pain, certain types of spastic disorders. So you think like multiple sclerosis or muscular dystrophy or something like that. And then there's some data around seizure that it could work. Cancer pain is another area where it has a little bit of benefit. So now you see three areas of benefit where there is solid evidence. But in Pennsylvania, we have 24 different indications that you can use this for. Some have data, some don't. So that's where the balance has to come. As far as just overall in the comparison study against opioids, this was a few years ago. I want to say maybe 6 years ago now, so it's considered somewhat outdated. But there was a study that looked at pain control, just general pain, non-cancer, for opioid against medical cannabis. And the outcomes were the same. But the difference was in the side effect profile, that people weren't going into wild respiratory depression with medical cannabis. So there has to be nuance with it. You also need to look at your employer. You need to look at any local regulations that are in effect, your insurance issues. This is an all-cash business, so if money plays into it. So there's evidence, yes. That's why it's great there's a pharmacist there, and we advocated for that at the state level when it did happen. But there's all this other stuff that you need to pay attention to as well before you can decide if that type of treatment is right for you.
Yeah, like we talked about before, a lot of pain treatment is very catered to that specific patient, and there's a ton of different factors that go into how we might help them treat their pain. So we definitely want to talk about this on a future show. And I think another good point you brought up is how important having a pharmacist is there, because we are the medication experts and can really help maximize the benefit that people do get out of this treatment.
Yeah, I remember when we were in the before times when we were waiting for the medical cannabis law in Pennsylvania to pass, and we were sitting down at the head office at PPA, and we were having a discussion of should we or should we not advocate for pharmacists to be involved with this. And we said this thing is going to be treated like a medication, so 100% we should. So it goes to show that our PPA advocacy efforts, so Pennsylvania Pharmacist Association advocacy efforts, were done to help pharmacists with jobs, and were done to ensure patients were safe when they were using this product.
Yeah, those are great points. And sorry to ruin it for you, Jamie, but in class, Dr. Franco brought in a pharmacist who worked in the area of medical cannabis, and she was explaining how she really helps patients find the type of medical cannabis that's right for them. So she finds the right strain, the right strength, and also the right delivery device. So whether that's a chewable or a vaporizer or something else that really caters to the patient and gets them the medication that they need.
Yeah, a lot of people think that medical cannabis means I'm going to go and smoke a joint in my house, and that's not what it means. First off, smoking is still illegal in Pennsylvania, so you're looking at drops under the tongue or a topical product, or a vape pen is something that people use. But yeah, when she came in, and if certain people are cool enough to take the elective next year, they'll be
It's on my list.
I know. I'm just poking fun. We bring her in every year. She's awesome, and she's on the board of PPA too. So she's she came on recently, and she's been a great asset to have.
Awesome. So we're going to start wrapping it up for this week. But Dr. Franco, give us some take-home points for the show.
I'd say that recognize that opioids are a part of treatment. They're a necessity in terms of the overall treatment of pain, but they're not the answer to the treatment of pain. No pill is the answer to the treatment. We have to treat everything that pain touches, and we have to approach every patient differently. And hopefully when these new guidelines come out, we keep in mind that they are, to quote Pirates of the Caribbean, we consider them guidelines. They're not laws. And I think the more and more we look at that, and hopefully the more and more the regulatory bodies like DEA in particular look at it as a guideline, and that there needs to be nuance with it, like there is with every other guideline, the better off patient care is going to be.
Yeah, that's a great point. It's always going to take clinical judgment on the part of the prescriber and pharmacist. So tune in with us next week, Wednesday, February 23rd from 1 to 1:30 for our next show. Thank you for listening to Generation RX Radio with Bryce, Jamie, and Dr. Franco. Until next week, keep it locked right here on 90.7 WCLH.